Hello, and welcome to Adventures in Neuropathology with your favorite neuropathologist, Andrea Gilbert. Today we are going to continue on our multi-part series of videos covering various topics in neuropathology. This is meant for board prep and board study, so for those of you who are residents in pathology, neurology, neurosurgery, or anybody else who might possibly be taking a test in the future on neuropathology or would just like to learn more about neuropathology, this is the video for you. So this video series is going to be focused on tumors that arise in familial tumor syndromes. And so that's going to be the focus of this series. We will have other series coming out with different focus and different topics of discussion. So be sure to subscribe and you can get those future videos. Okay, let's get started. All right, so our next mystery case is this guy here. And the question is, what is the most likely diagnosis? And then what is the most likely syndrome? So let's take an effect of what we have here. This is a sagittal view and this is an axial view, both post T1 contrast. And what do we see here? We see a cyst in the posterior fossa, and that cyst has an enhancing nodule on the wall side. This is a mural nodule, right? So when you guys hear the words cyst with an enhancing mural nodule, there should be 4 diagnoses that immediately come to mind. Okay, in the pediatric population, it's 3 diagnoses. So it kind of has a little rhyme to it. Okay, and the rhyme is PA-PXA ganglioglioma. PA-PXA ganglioglioma. Okay, PA-PXA ganglioglioma. Okay, and so that little rhyme is a cyst with enhancing mural nodule, especially happening in the temporal lobes in the pediatric cases. Absolutely want to think about PA-PXA ganglioglioma, with PA standing for Pilocytic Astrocytoma, PXA stands for pleomorphic xanthoastrocytoma, and ganglioma is ganglioma. Okay. But in the adult population, we want to add one more, and that is hemangioblastoma, especially if it's occurring within the posterior fossa. So when we, so if you didn't have this MRI to help you, would you be able to recognize this on just the morphology alone? And I would say that you could. If all I gave you was this information right here, you should be able to recognize that that is a hemangioblastoma. So what do we see here? We see a very vascular tumor with a lot of blood vessels, okay? And we also see some of the tumor cells are kind of clear cell, and they have this kind of bubbly little clearness to them. And then they are classically, characteristically positive for alpha inhibin, okay, inhibin alpha. So if this was the only, if you just kind of block out everything on the left side of the screen and just focus on what's on the right side of the screen, you should be able to make a diagnosis of hemangioblastoma, and that we have these cleared cells, they've got this kind of lipid-filled cytoplasms, and they're positive for inhibin. Very classic. So the diagnosis here is hemangioblastoma. When I talk to my pathology residents about this, this morphologic appearance very much resembles a renal cell carcinoma clear cell type. So clear cell renal cell carcinoma looks very similar histologically, and so we always have to rule that out. And the reason why we really need to rule that out is because both hemangioblastomas and clear cell subtype of renal cell carcinoma both commonly occur in this one tumor syndrome. So what is the name of the tumor syndrome? The familial tumor syndrome that is classically associated with hemangioblastoma and renal cell carcinoma, it's a VHL, okay? So von Hippel-Lindau, classically associated with hemangioblastoma, but you have to think about renal cell carcinoma. So what's going to kill the patient? The patient, now this can cause increased intracranial symptoms, but the actual tumor itself is very small. The issue arises when the cyst gets big. So usually it's the cyst that creates the issue, but the tumor itself is actually very small. So usually what we look for is what's going to kill the patient is going to be the renal cell carcinoma. So how do we know that it's not metastatic renal cell carcinoma? The stains are what we use mostly. Okay, so inhibin is going to be classically positive in the hemangioblastoma, and it will be negative in renal cell carcinoma. Renal cell carcinoma will be positive for a bunch of other things like EMA, RCC, PAX8, things like that. And they will be negative in the hemangioblastoma. Okay, so renal cell carcinoma tends to have this very, 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 very clear appearance to the cytoplasm, whereas hemangioblastoma tends to have this kind of bubbly, not so clear look to the cytoplasm. Von Hippel-Lindau, it's associated with CNS tumors, hemangioblastomas. Now, the vast majority of tumors that, the vast majority of hemangioblastomas that arise in your average run-of-the-mill person, usually that's sporadic, but in the context of von Hippel-Lindau, you want to be suspicious of that if you see it outside of the posterior fossa. So if you have hemangioblastoma arising within the supratentorial region or in the spinal cord, you really need to think about, okay, what does this person's kidneys look like? And that's the thing that's going to kill the patients, not the hemangioblastoma. It's going to be the renal cell carcinoma. So that's the thing that you need to think about. So when you hear the words hemangioblastoma, you automatically need, your gut reaction should be, what does his kidneys look like, because of the possibility of VHL. VHL is associated with alterations in chromosome 3, and renal cell carcinoma, the clear cell type, also has alterations in chromosome 3. Okay, so all right, so that is a whirlwind review of von Hippel-Lindau syndrome. Okay. If you liked that video and you feel like you might have learned something, please feel free to check us out on our website at Adventures in Neuropathology. You can also find us on Facebook, Twitter, Instagram, and YouTube. In addition, if you are interested in learning more about neuropathology, I authored the Neuropath chapter of this new book by Daniel Mais. This is Surgical Pathology Review. It's chock full of information in a bullet point format, great for review and study, so feel free to check that out. Okay, I'll see you on our next adventure.